Good morning. This is my presentation on the vascular anomalies of the orbit. I'm going to go through some anatomy background first, uh, mostly about the vascular supply. There are two main sources of blood to the eye, the ICA through the ophthalmic artery and the ECA through the infraorbital artery. The ICA is by far the majority of the blood supply to the eye, so we'll be talking about that a little bit more. There's a mnemonic for the branches of the ophthalmic artery, but it's not in the right order, so keep that in mind. The central retina artery is the first branch of the ophthalmic artery. It follows the optic nerve inferiorly, and then about 12 millimeters posterior to the globe, it will pierce the optic nerve and travel inside of it. The posterior ciliary branches are second, followed by the lacrimal branch, which is kind of in the lateral portion of the orbit and supplies the lacrimal gland. The muscular branches supply all of the um, orbital muscles except for the inferior oblique and inferior rectus. And then the supraorbital branches next, followed by the ethmoids. And then the terminal branches are the dorsal nasal and the supratrochlear. This is a pretty good schematic, kind of discussing the different branches and their relationship. So I think it's pretty helpful to remember what order they come off in and the direction. And then from the external carotid, we have the infraorbital artery, which travels in the inferior portion of the eye and supplies the inferior rectus and inferior oblique. In terms of the eyelid, there are palpebral arteries that supply um, the eye from either side. So there's a superior and inferior branch that's coming from the lateral aspect, and it's supplied by the lacrimal artery. And there's medial palpebral arteries that are kind of symmetrically coming from the medial canthus. The veins of the eye are valvulous, which is significant in that infections have much higher risk of traveling deeper into the skull and the cavernous sinus. And the variation of the drainage patterns in the veins is much greater than that in the arteries. So the branch points is not as consistent. This is our basic breakdown of the different vascular anomalies. Um, Remember, under the tumors category would be hemangiomas, which is the large chunk of that, and then the vascular malformations would be AVMs, capillaries, venous, and lymphatic. And we're going to start with the venous malformations of the eye because these are the most common. So venous malformations make up about 50 to 60% of all orbital venous anomalies. They usually present in the 30s and 40s of life. 70% become symptomatic at some point. And then I'm going to break down the different types. There's three of them. There's type 1, which are low flow. They're often called cavernous. And if you hear the word cavernous hemangioma, it's somewhat of a misnomer. Truly, what they are cavernous venous malformations. Um, the main feature of these is that they're non-distensible, which means that if you were to Valsalva or try to put extra pressure in your eye, they would not increase in size. Because of this, they're almost always symptomatic. Um, and those symptoms typically are gradual onset axial proptosis, blurred vision, pain, diplopia, and then they can have gaze-evoked amaurosis, meaning that they lose vision when they look in a certain direction. Then type 2 venous malformations can be called orbital varices. These are the type that are distensible, meaning if you were to do a Valsalva, then the size would increase. Uh, some of the time, this is obvious on exam, so about 60% will have proptosis with Valsalva, but the other 40% you would have to get an MRI and then have them Valsalva during the exam to see the distensibility. Because these can stretch and grow larger when the pressure increases, The risk of them spontaneously hemorrhaging is lower, as well as the risk of thrombosis is lower. And then type 3 are much less common, but they're essentially infiltrative versions of the venous malformations. On a scan, you're going to see a round or oval shaped mass. It's usually isoechoic with the muscles within the eye. About 80% are intracoronal, which you can see in this imaging here, and they're typically well circumscribed. To treat venous malformations of the eye, you treat them if they're symptomatic. Um, some There's four basic options. You can embolize them, which is generally better for saccular dilations than for like a tangled plexus. Understanding that this is not uh, truly a cosmetic option. If the malformation is close to the skin, it's going to look bad after you embolize it. A surgical excision, CO2 laser, and alcohol sclerotherapy are all options as well. The big point about alcohol sclerotherapy is that if you inject it near the optic nerve, you can burn the nerve and potentially blind them. So you have to be careful about this. The only indication or situation where you might use it is if the mass is very superficial or away from the optic nerve. And this is from a multidisciplinary paper that I found, which is kind of helpful, but it breaks down the categories and the recommended treatment for those categories. So for a distensible, superficial, well-circumscribed venous malformation, you might do alcohol sclerotherapy. If it was larger or diffuse, you might do the CO2 laser. If it was distensible but deep, often you do embolization and surgery. And if it's non-distensible, then surgical evacuation of a clot is the recommended treatment. This is an example. I think it's very helpful to kind of see. In part A, you can see a child with a um, left lower eyelid venous malformation. And in part B, he's doing a Valsalpin maneuver, and you can see that the mass is larger, which would mean it's a type 2 or a distensible venous malformation. And then the imaging in part C. And if you remember the guidelines we just kind of went through, alcohol sclerotherapy would be a good option for this since it's kind of discrete, superficial, it's distensible. Injecting it with some alcohol is low risk to affect the optic nerve at this location. And that's what they did in image E, and then F is the end result. An alternative, which I think is interesting, is this one in which they made an incision over the malformation and then burned it with the CO2 laser and then closed the incision back. Moving on to hemangiomas. These are the second most common kind of vascular anomaly in the eye. So 25 to 40% of orbital vascular anomalies are hemangiomas. Remember, there's infantile versus congenital. The most common location in the eye is the upper eyelid or the superior orbit. And 43 to 60% of patients with hemangioma of the eye are going to develop amblyopia. This can either be due to strabismic amblyopia, because it's involving the muscles, or it could be deprivation amblyopia due to ptosis of the involved eyelid. Just to recap quickly, infantile have GLUT1 positive, congenital do not. Infantile generally proliferate in the first 4 weeks to 4 months, then they involute. Um, Congenital are typically fully formed at birth. Some involute, some do not. So this is an image of a baby with a left upper eyelid uh, hemangioma who was treated with propranolol, which is the mainstay of treatment for infantile hemangiomas. And you could see in this case that, he had some ptosis of the eyelid that certainly could be affecting his vision. And within just 14 days of treatment, he has significant improvement. So the main indications to treat a child with eye hemangioma is anything that's obstructing the vision, any cause of exposure keratopathy, So if they're having trouble blinking or tearing or anything like that, optic neuropathy or lesion-induced amblyopia. Majority are going to receive treatment, as I mentioned. 43 to 60% could develop amblyopia without treatment. So propranolol is generally given and titrated up to 2 milligrams per kilogram per day. The main side effect is hypoglycemia. It's something that you have to be watching for, and bronchospasm. So you want to ask about asthma history. AVMs are the third most common. Less than 5% of orbital vascular anomalies are AVMs. They're high flow, often congenital, but generally present in adulthood, and angiography is going to be more important imaging for these patients. Generally, you treat them with embolization plus surgical excision. Remember that if you're embolizing something, uh, and glue is a pretty common embolizing um, substrate for high flow lesions, um, it can have retrograde flow after you inject it. So the closer you are to the ICA, the higher the risk of stroke is. So if you have a lesion that is branching off of ophthalmic really close to ICA, and you send them to get embolized, just kind of have in the back of your head, like, that certain patients are going to be at high risk for stroke. This is a case I thought was interesting to kind of run through. A 47-year-old woman complained of persistent pain, discomfort, increasing redness and size of a right periorbital lesion present since childhood. You can see the imaging here. And then this is an MRI of the same patient. And one thing that I'll point out in the arrow in image A, you have a flow void where there is like the scan is black because the blood in that area is moving so fast the MRI doesn't pick it up. This is angiography, and then the treatment was surgical excision after embolization. Lymphatic malformations are the fourth most common, less than 5%. They're highly variable. There's two treatment options, generally surgical resection. If you don't get all of it, it can come back. And then sclerotherapy with OK432. The significant aspect of the sclerotherapy is that immediately after you inject it, you will have significant swelling, and it will eventually go down and the lesion will die. But in the interim, you have to be cognizant that if you inject a lesion that's close to optic nerve, it is going to swell up significantly, and then you could blind the person or cause damage to the orbit. So these are some examples of lymphatic malformations of the eye. And then the example of the sclerotherapy in image A, you can see the lesion. In image B, this is after sclerotherapy. So you can see how swollen it's gotten. And then image C is the final result, which looks much better. That was all for me. Thank you.